I'm going to be sending you a review sheet, and basically it's going to tell you what it's called things to know for the second exam. So the first thing we're going to want to know is going to be the 4 ABIs. Remember the 4 ABIs we've talked about several times, we've done a lab with already, and that's going to be the 4 ABIs of respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. Those 4 ABIs, as we've talked about already, and it's summarized very easily in the book, are going to each have 3 levels of compensation. So each ABI has 3 levels of compensation. First one is going to be UC, or uncompensated. The second one is PC, or partially compensated. And the third one is FC, or fully compensated. The next thing that you'd want to know for the test is what I would call what are the complications of an NG tube. So complications of a NG or nasogastric tube. Well, if you think of the anatomy of the body, I've got my esophagus coming down. The esophagus then, of course, is passing through the diaphragm, passing actually through the hiatus, and then it's going into the stomach. So if this is my stomach, and of course we know the stomach has acid in it, it's got hydrochloric acid in the stomach. Remember, hydrochloric acid in the stomach has something approximate pH of 2, so it's very acidic. A nasogastric tube is actually used oftentimes when the patient is after surgery or post-surgery for nausea. So somehow to treat nausea. And so therefore, what you're basically doing is taking a tube, an NG tube, and you're passing it down through the esophagus into the stomach. And so therefore, if you think what you're doing here and connecting this to vacuum. So when I put in a nasogastric tube, what I'm doing is I'm pumping out HCl, hydrochloric acid. Well, if I pump out hydrochloric acid, that means that I'm losing acid. And since this is metabolic, this is certainly nothing to do with the lungs. When I lose acid, it's going to lead to, if I don't monitor it carefully, especially the way I would irrigate it, as I lose acid, it will actually turn me to go into a metabolic alkalosis. So that's one thing you want to really understand, because it will kind of give you the same concept of when someone throws up or vomits, they lose acid and go into a metabolic alkalosis. Always think of the example I gave you of a seesaw. Put 100 pounds on one side, 200 pounds on the other. Either you got to take 100 pounds out of the 200-pound side or add 100 pounds to the 100-pound side in order to balance it. 3, the third thing you want to make sure you understand is what's the effects of aspirin on the respiratory rate. or all take aspirin, we know aspirin is ASA or acetylsalicylic acid. So the first thing you start thinking of, that the classic example is you've got a 4-year-old child, and the 4-year-old child swallows 325 milligrams of acetylsalicylic acid. Well, the first thing most people would think is that if I swallowed a bunch of acid, is you would think that it would cause a metabolic acidosis, because we've overloaded the body with acid. But in effect, that is not the initial mechanism. The first thing that happens when we swallow acid, or acetylsalicylic acid, it's going to cause stimulation. So it stimulates the pons and the medulla of the midbrain, or of the brain stem. And it's going to lead to hyperventilation. And therefore, we know that hyperventilation always causes respiratory alkalosis. So it's the loss of that CO2 by hyperventilating. This could put you in an alkaline state by taking too much aspirin. That's the immediate effect. So the immediate effect is going to be a hyperventilation and respiratory alkalosis. But then, after about 25 to 40 minutes after ingestion, that acid now, that ASA or aspirin, is going to go into the bloodstream. And therefore, what's going to happen, we're going to have a respiratory alkalosis, which is the initial problem, which is going to be superimposed by a metabolic acidosis. So if you think of the consequences of that, if someone was breathing too quickly, you had your 4-year-old in the emergency room within 20 minutes of ingesting the aspirin, and he was breathing at 60 times a minute or 40 times a minute, the first thoughts would be of the treating physician or whoever was the primary care on the case, is to give the kid something to slow down his respiratory rate. Either giving him a benzodiazepine or even putting him on a ventilator and controlling his ventilation, and after paralyzing the respiratory muscles. The problem is, by doing that, you in effect would be killing the child, because about 40 minutes later, all that aspirin and that acid is going to kick into the bloodstream. And of course, the way to treat metabolic acidosis is hyperventilation. So therefore, by carefully monitoring the child within that hour will completely turn around and go back to normal. So that's a very significant concept to understand. The next thing we want to understand is the respiratory tree. You think of the respiratory tree, just kind of think of sticks coming down, so it's very linear. So the first thing, remember, we're going to have is my trachea. The trachea is going to bifurcate or split at the carina. And when it bifurcates or split, it's going to go into the RPB, or the right primary bronchus, and the left or LPB, the left primary bronchus. The right primary bronchus then is going to go into the lobes of the lung, because the right lung has got 1, 2, 3 lobes. And this is right and this is left again. So you're going to have 3 lobes, and that's therefore going to be secondary bronchi. So this is secondary, and this is a secondary, and this is a secondary. And since I've got 3 lobes on the right lung, I'm going to have 3 lobar bronchi. On the left side, because of the position of the heart in a cardiac notch, I'm going to have a secondary bronchi and another secondary bronchi. So on the left side, I'm going to have 2 lobar bronchi. Now the secondary bronchi, whether it's on the right side or the left side, and there's variations on this, but for example, on the left side, we could easily say we're going to divide that into 1, 2, 3, 4, 5. So we're going to have 5, we're called tertiary here, bronchi. And then same down here, 1, 2, 3, 4, 5. 5 more tertiary bronchi. And because they're tertiary bronchi, they're called segmental. So therefore, we're going to have 10 segmental bronchi on the left side. And the same over here. We could just put 4 up here, and 3 here, and 3 down here. And therefore, that's going to again come with 4 tertiary, and 3 tertiary, and 3 tertiary, which then leads us into 10 tertiary bronchi or segmental on the right side. And you add those two together, we end up with 20 tertiary or segmental bronchi. Therefore, those are called bronchopulmonary segments. Significance is that each segment has its own air supply and blood supply. So therefore, years ago, when someone had a tumor in their lung, you have to do a pneumonectomy, remove the entire lung. But once they realized that the lung's divided into 10 bronchopulmonary segments on each side, you could literally remove 1, 2, or 3, or 4, as many as you want of those segments, and still have a viable lung on whatever side we had a tumor or a pathology. Also on the respiratory tree, we also want to realize that just writing down the names of these structures, so just remember you've got trachea. Trachea goes to primary bronchi. Primary bronchi to secondary bronchi. Secondary bronchi to tertiary bronchi. Tertiary bronchi to an alveolar duct. Alveolar ducts go into an alveolar sac. An alveolar sac into an alveolus. So therefore, primary bronchi, how many do we have? Well, we've got 2 primary bronchi. We've got 5 secondary bronchi. We've got 20 tertiary bronchi. and then those subdivide into ducts, sacs, and alveoli. Now, when we look at these tertiary bronchi, between the tertiary bronchi and the alveolar duct, we've got subdivisions. And that's where we start talking about gas exchange rather than bringing air in or bringing air out. So if you go to this tertiary bronchi, so we'll just make this another very simple right here. If we had air that came in and finally got to the tertiary or segmental bronchi, we then would take that and bring it down to what's called a terminal bronchiole. Remember, it just divides smaller and smaller and more of these tubes. Between here and here, there's somewhere around 20 more what are called subdivisions. Terminal bronchiole goes to a respiratory bronchiole. And then, of course, the respiratory bronchiole eventually goes into an alveolar duct, alveolar sac, and then alveolus. So all the way down from the trachea up here, so this is bringing air in, all the way down, this is conducting air, all the way until we get to end of the terminal bronchioles. So all that happens between the trachea and the terminal bronchiole is air conduction. It's not till we get to out of the terminal bronchioles that we start having conduction plus exchange. And the reason is because the epithelium gets thinner and thinner and thinner as we move our way down the tree. Number 5 is to understand COPD. Remember, COPD is going to be fully compensated respiratory acidosis. So make sure you understand that COPD, the person when COPD relies on hypercapnic versus hypoxic. So if I have COPD, I rely on hypoxic drive. Hypoxic means decrease O2 versus a normal person, and they rely on hypercapnic drive. And that's going to be increased CO2. Number 6, know the respiratory volumes. Again, go over the book and go over any of the sheets I've given you. Those are the things like the RV, IRV, TV, ERV, VC, TLC. Understand what those terms mean and how two or more volumes make a capacity. Number 7, let's see, that's 5. I'm sorry, that was 7, that's 7. Number 6 is distinguished to intrapleural, interstitial, and HTX, PTX, ATX. Remember, intrapleural is between the pleura. So remember when I talked on the prior lecture, this space in here is the intrapleural space. The other one is going to be the interstitial space. Remember, the interstitial space is going to be that space between an alveolus and an alveolar capillary. So that's interstitial. And the other one, of course, we've already talked about. You want to remember the difference between an HTX, a hemothorax, a PTX, a pneumothorax, and an ATX, which is atelectasis or collapsed alveoli. Number eight in the review sheet says understand the structure of the nephron. We just went over that about a few minutes ago, so make sure you understand the nephron structure. Number 9 concept, understand RBF, GFR, and TBV. Again, we just reviewed that in this lecture. 10, understand hypoxic and hypercapnic drive. Again, the difference is, remember, hypoxic drive is going to be when we rely on decreased O2. Hypercapnic drive is relying on increased CO2. Number 11, what is a right main stem bronchus? Remember, in the anatomy of the body, as we go from the trachea and the right and left side, so this is right and this is left. Remember, the right is a straight line down, the left is coming off at an angle. So therefore, a right main stem bronchus means that if we put an endotracheal tube down, it would tend to go and slide into the right main stem or into the right lung. Number 12, the significance of the costal vertebral angle. Remember, that's going back really to 168, but remember, costal vertebral angle is where my last rib, so my last, and actually my vertebral chondral rib, or my false rib, where that connects to my vertebrae, is the costal vertebral angle. Significance of that is pain scale. So if this was my CV angle, and I had pain above, so if there was pain above that angle, that would make me think that I've got a nephritis or a kidney infection. If I had pain below the CV angle, I think more of a cystitis or a bladder infection. Number 13, distinguish glomerulonephritis and urethritis. Just remember that glomerulonephritis is talking about the ball of capillaries and the nephron itself. Well, that is a true kidney infection. A urethritis is just an inflammation or infection of the urethra. So that's going to be the pain or burning when we urinate. Number 14 is understand the function of the paratubing glomerular fenestrated capillaries. Just remember, the glomerular capillaries are the ones that are coming off of the afferent arteriole into the efferent arteriole. So these are my glomerular capillaries. And those glomerular are going to produce filtrate. My paratubular capillaries, which we just talked about, are the ones that on the nephron, I'll just make it a very simple diagram, but those are the ones that are coming here. And remember, I said this is my renal artery coming here, and this is eventually going into the renal vein. So coming from that renal vein are going to be a series of capillaries that are going to filter, secrete, and reabsorb the filtrate. Be able to make calculated respiratory formulas for volumes and capacities. Make sure you memorize those 3 formulas for understanding volumes. So you want to memorize the formulas. They're right in your book. Very simple. We actually went over those with a worksheet. Number 16, Kushmal respirations. Kushmal respirations, you're often going to see, they're always going to be with a diabetic patient. So make sure you understand the definition of Kushmal respirations. 17, review the gas laws and know a definition of each. If you look in the book, there's some gas laws, such like Boyle's Law. So look up the 4 gas laws that are in there. Make sure you have a definition. And then finally, I always tell students, make sure you know your ABI charts. Memorize and understand. Don't just memorize the chart, but be able to reproduce those when you're taking an exam.